actually put this on the screen. There we go. All right, so we're going to talk about several things. You know, lots of stuff about, chemical control of bacteria and antibiotic control of bacteria. Here, this is actually an actual antibiotic. It's a tetracycline, and we're going to talk more about that in a second. But what you can see here is the way it's binding to the protein and where it's interfering with actual interactions in this. So it's actually really, really interesting. We'll talk more about that in a second. But it's actually getting in the way of certain interactions by binding to the active sites of certain proteins on there. Hold on one second. My lab assistant is having problems. Okay, there we go. So we're going to play this little video. I don't know if Dr. Loss, no, you guys have Dr. Kabara, but this is actually really cool.
So what we ended up building was basically a petri dish, except that it's 2 feet by 4 feet. And the way we set it up is that there are 9 bands, and at the base of each of these bands, we put a normal petri dish thick agar with different amounts of antibiotic. On the outside, there's no antibiotic. Just in from that, there's barely more than the E. coli can survive. Inside of that, there's 10 times as much, 100 times, and then finally the middle band has 1,000 times as much antibiotic. And then across the top of it, pour some thin agar that bacteria can move around in. The background is black because there's ink in it, and the bacteria appear as white. First, you see they spread in the area where there's no antibiotic, up until the point they can no longer survive. Then a mutant appears on the right. It's resistant to the antibiotic, it spreads, until it starts to compete with other mutants around it. When these mutants hit the next boundary, they too have to pause and develop new mutations to make it into 10 times as much antibiotic. And then you see the different mutants repeat this at 100. And after about 11 days, they finally make it into 1,000 times as much antibiotic as the wild type can survive. And so we can see by this process of accumulating successive mutations that bacteria, which are normally sensitive to an antibiotic, can evolve resistance to extremely high concentrations in a short period of time.
So there you go. It actually shows you, really interestingly, how tiny amounts of antibiotic resistance can lead to huge antibiotic resistance. And it only took 11 days to do that. By the way, fun fact for our Cool Science Thing Week, the ink that they use in the background is squid ink because that is non-toxic to bacteria. They don't care about it, so it's chemically inert. And that's the reason why they use it. So yeah, they use squid ink to make the background black. Pretty neat. Anyways, so there you go. So antibiotic resistance develops under conditions that are ideal for the bacteria to survive that antibiotic. So we talk about this all the time, and I'm sure you guys will see that when you guys deal with any kind of patients. You know that if they're not taking the antibiotic appropriately, so that's something that humans are bad at doing, is taking pills when they're supposed to, antibiotic resistances can occur. So they get, oh, I feel better, I'm just going to stop taking the antibiotic. And now something that was slightly exposed to the antibiotic that would normally not be able to survive now has a chance to develop a resistance. And you do this a couple of million times over the course of a decade, and now we have very resistant bacteria to antibiotics. So, unfortunately. Okay, so some background information. For each of these antibiotics and chemotherapeutic agents, anything that we're talking about, there's a mode of action. You guys need to know what that is for each of these. You also need to know whether or not it's bactericidal, that is, that it kills bacteria, or it's considered bacteriostatic, and that just means that it inhibits it from growing. It doesn't do a great job. You know, it doesn't kill them, it just kind of slows them down. And when you slow bacteria down, that gives your immune system time to go in and attack it and kill it. You also need to know what the therapeutic index is. It's actually really easy. It's a simple equation, and now I'm looking at my slide and it got moved over. Let's fix that briefly. Okay. There we go. I don't know why it got moved over, but that's what it is. Okay, so therapeutic index. There is a toxic dose, that's how much medication must be taken before an undesired side effect is seen in a patient. There's a therapeutic dose, which is the amount of medication that must be taken before the desired effect is seen. And the index is a safety measurement of how, toxic dose divided by therapeutic dose. It's a really easy index. What you want is a number that's as high as possible. That means you'd have to give a huge amount to get negative side effects in the patient, and only a little bit to get the desired effect. So a great example of this is penicillin or ampicillin. There's a therapeutic index of 100. So you'd have to take 100 times more than what you do effectively of the therapeutic dose to get undesired side effects. In fact, you'd have to take so much ampicillin, there would be more than in any given bottle of medication that they give you. We're talking kilogram levels. It's a lot. So that's a very safe drug. Now, something like gentamicin, though, you only have to take it a little bit more than you're supposed to, and then you start seeing those negative side effects. It's just a teeny tiny amount, so it's not a very safe drug. You can start seeing those undesired side effects pretty easily. And even though there's a number here, you might be like, well, the number's fine, it's 3, right? That's not always true, because people have different issues and different susceptibilities to these. This is just kind of a general number. So we know that streptomycin or gentamicin is less safe in general than something like ampicillin. So you don't generally want to give this unless you're absolutely sure that they need to do this. So that's generally how it works. Now, we want to choose some that have the highest possible one, but sometimes it's not possible. You can have therapeutic indexes where it's fractions of a point. So you always get negative side effects no matter what dose you give them. A great example of these are things like cancer treatments, and especially antifungal treatments. Antifungal treatments are notorious because their cell types, fungi, are eukaryotic, much like our cell types. So something that works on them has a high likelihood of working on us, or at least getting caught by our cells that are meant to filter out our blood. A great example of this is liver. One of the standard treatment for toenail fungus sometimes will just straight up kill people because it'll shut down their entire liver, and there's really not much you can do about it unless you monitor them before you give them the drug. So you give them the drug, check their liver enzymes, make sure there's no pre-existing condition, and then you give them the drug and immediately start testing them for any kind of liver problems, and if you can catch it pretty soon. But it can actually kill people really, really fast. It is not, it's not a pleasant drug. It's a very effective drug, and for some people it has no issues whatsoever, but it can basically kill you pretty fast. And a lot of antifungals fall under this category where the only time that we would give you them is when the consequences of living with the fungal infection are going to kill you much more quickly than giving you the drug that will, drug won't kill you as quickly as the fungal infection will. So there you go, interesting facts. Okay, antibiotics generally fall into classes. There are some more classes than what's listed here. These are kind of the major ones that you should know about. For each class, you do need to know what an example, kind of the quintessential example is within this, and I'll tell you guys these are the quintessential examples, the really, really common ones. And we're going to talk about each one here in a second, but you do need to know an example of each one within this. Okay, so sulfas, everybody calls them sulfa drugs. They're technically called sulfonamides. Sulfasalazole is like the common one that everyone prescribes. There's other ones too. The way it works is through bacterial it's bacteriostatic. It does its competitive inhibition for folic acid synthesis. So we consume our folic acid. We don't synthesize it, so it doesn't matter if we try to interrupt our stuff. We just consume it from our food. We don't need it, but bacteria need it, and they need to synthesize it themselves. And the way they do that is with an antimetabolite, with the metabolite PABA, and so you need this present to make folic acid. And if you don't have folic acid, you can't make things like amino acids and purines. So it's very important. So basically it's getting into the binding pocket of where you make folic acid for the bacteria, and it's just interrupting that constantly. So you're just kind of slowing things down for the bacteria. It can't make DNA, it can't make protein as efficiently. There are some side effects to this. The most common one is allergic reaction. I'm actually allergic to this one, can't take it. It can also cause some other things like blood dichriasis, crystalluria, crystals in urine, which is the most common side effect. It's not a very serious one, it just hurts. Hematuria and thyroid hyperplasia, so it can cause thyroid problems. But most of these are like really uncommon. Like we're talking, 0.001% of people would get these ones. Far more common is allergic reaction and crystalluria. Broad spectrum is what it's generally considered, so it handles a wide variety of bacteria because all bacteria basically use the same synthesis pathway to make folic acid. It's primarily used against gram-negatives. It's just really good at going through the gram-negative cell walls. Very simple to do that, so that's what it basically is. So that's sulfa drugs. Next one is penicillins. Penicillins include things like penicillin, amoxicillin, ampicillin. They all have this thing called a central beta-lactam ring, which is this guy right here. It's a heavily constrained structure, so it's really good at reacting quickly with things. Specifically, it screws with the cross-linking of NAM units on the peptide glycan molecule. So as they're trying to form a nice structural cell wall on gram-positive bacteria, it's got these kind of layers that kind of intertwine with each other. This reacts with that, it disrupts it, so now their cell wall is not as structurally sound, and it causes them to lyse. So it is considered bactericidal. It is most effective against gram-positives because, of course, the peptidoglycan layer on them is on the outer surface, and it's much more thick and important for cell rigidity. The side effects, most common, are just allergic reactions. That is, hives, anaphylactic shock, respiratory distress. There's really not a lot else to this other than like kind of common side effects, like sometimes you'll get diarrhea or things like that. And to get even more serious consequences, you'd have to be taking huge amounts, like kilograms per kilogram of body weight. It's a lot. So it's a very safe drug, generally speaking, aside from the anaphylactic shock. The next one is tetracyclines. These include tetracycline, oxytetracycline, doxycycline, which is kind of the quintessential commonly prescribed one, as well as minocycline. And they have this structure right here. And if you guys remember, in the previous, the very beginning slide, I showed you guys a molecule binding in there. And what it's doing is it binds to the 30S ribosomal subunit, and it prevents bonding between tRNA amino acids and the mRNA codon. So it's basically getting in there, in that little binding pocket, and it just kind of interrupts the proper interactions, because to bring the tRNA in with the mRNA so that it can put the right protein in, you need to have things coordinated really well. Well, this guy fits really nicely in that pocket, and it has all of these extra oxygen sites on it, and that makes it really, really good at just kind of interfering with everything, and it just messes everything up. So it is very good at doing that. It is considered bacteriostatic. It's just slowing down that process. It doesn't cause any problems, really. It just slows everything down. It is considered broad spectrum. It works on pretty much all bacteria. It's not common resistances, but some are starting to develop. Side effects for this one. It's a bit more dangerous. Common side effects are nausea and diarrhea. For children, which we don't give to anymore, it causes discoloration of the growth plates and unerupted teeth, so it can cause kind of these weird banding effect on their teeth. We didn't know that initially when we started doing this. Turns out that that's a problem, so we stopped giving it to children. More serious one for older people, so not really older people, just people that are more adult-like. It can cause damage to kidney and livers. One downside to it is it chelates really well in milk or calcium, so if you take it with something like breakfast, and you have a bowl of cereal, it's going to chelate in that milk. That means it's going to come out of solution, and it's not going to be absorbed by your body. It just happens to coordinate really well with the calcium ions and doesn't work very well. So, there you go. Next one up is fluoroquinolones, which are my favorites. They have a unique structure. What they do is they inhibit topoisomerase 2 and 4, which prevents DNA replication and transcription. If you guys don't remember what that is from basic biochemistry, it's not very basic, but it basically, when you uncoil DNA, you have to kind of pull it apart, but eventually you have to kind of nick it and then unwind it so it doesn't supercoil too much. That's what topoisomerase does. It's there for unwinding DNA and making it come apart easily. How this works is it actually has the side of it is like a nucleoside. So this is adenosine, part of DNA. This side looks like all of these sides, especially to the molecules here. And so the name fluoroquinolone, it's got a fluorine on it, and then it's got some extra moiety coming down off of the nitrogen. So this nitrogen here, and all of these fit really nicely into the pockets of those replication machineries, the topoisomerases specifically, and it just gets in the way and makes it not function. If you cannot replicate DNA, if you cannot correctly uncoil DNA, you can't replicate, and that's bactericidal. Now, the common example is ciprofloxacin. That's probably the most commonly prescribed one. Right after that's levaquin and enrofloxacin. Side effects for this, a little bit more severe. It can cause erosion of the cartilage, cartilagen, weight-bearing joints in children. So it can basically erode the area between joints that hold them up and create smooth movement of those joints. So it does that specifically in children. It also causes tendon rupture. So generally you don't want to avoid giving this to like people who are athletes or power lifters, because their tendons are already under heavy stress and they can actually snap the tendons away from the bones. It's right where the tendons connect to the bone tissue. And so you can actually have them rupture pretty easily, which is bad. Other common ones are things like vomiting. It can cause rash, an ascending rash. Specifically, the ones that's really common is it'll start at the chest and start going up towards the throat. My wife's actually allergic to this. We didn't know. When she got a prescription for it, we noticed right away that she had a rash on her chest, and she was like, wow, that's really weird. I'm like, stop taking that antibiotic because you're going to die, because it will eventually make you stop breathing, which is bad, generally speaking. It can also cause abnormal liver tests. So if you get somebody who has like liver failure, you can start messing up the tests really significantly, so you don't want to do that. And of course, nausea and diarrhea, as most antibiotics do. Okay, macrolides. Erythromycin is the general one, or Z-Pax. It has these very large ring structures. The way it works is it binds to the 50S ribosomal subunit. So if you remember the other one, it binds to the 30S, this binds to the 50S, which is the larger subunit, and it inhibits peptide elongation. It is considered bacteriostatic. It's only slowing that down, it's just getting in the way of the binding properly. It's effective against most gram-positives and some gram-negatives. Its most common issue is gastrointestinal upset. It's really not that dangerous. If you guys know, like Z-Pax, like commonly prescribed for almost anything, because it's super safe and you only have to take a couple pills to get a really good effect. Hepatic injury is another common issue. So it can go through your liver and cause damage there. Less common, but it does happen from time to time. The last one is aminoglycosides, which are the far more dangerous ones. Gentamicin and streptomycin are the common ones. This binds to the 30S ribosomal subunit. Just like before that we were talking about, this one's binds to the 30S, but it does a little different. It's considered bactericidal. It's very effective against gram-negatives. And the way it does this is it actually interferes. So this is the molecule right here, binding. So it gets into this. It gets into this little area, this little pocket of the 30S ribosomal subunit. As it's reading mRNA here, what this does is it actually puts in codon misreads. So it starts shoving in the wrong amino acid into any protein that the bacteria is trying to make. And you only need to mess up one amino acid to have an entire protein just stop functioning. I mean, sometimes you can get away with it with a couple of mutations here and there, but any kind can totally shut it down and basically cause it to die. The proteins will start chelating out of solution, resting on the cell membrane, causing it to lyse. It is really, really effective. Downside, it is pretty dangerous. Most common thing is allergic reaction, cause nausea, and cause loss of hearing, so it will destroy the nerves in your ears for whatever reason. I actually don't know the reason behind that, but it does. And renal damage, so it will shut down your kidneys. And it can actually do both of these last two pretty severely. And generally you don't want to give these unless you know that they need to be given. Remember, they have that very low therapeutic index. That means that they're not super safe. But you tend to give them only when it's kind of like really important that you kill something quickly and effectively, and you know it's already got antibiotic resistances. But less commonly prescribed now. It used to be given all the time. Like streptomycin used to be like the default for a lot of childhood infections, and it's not anymore. Kirby-Bauer, antimicrobial sensitivity procedure. So Kirby-Bauer is the test. You need to know that. We use something called a Mueller-Hinton agar plate. It is slightly different than TSA. It helps kind of optimize bacterial growth and kind of evens out anything that they might put that would like interfere with the antibiotics. So it's evens out the way they grow. So Mueller-Hinton is the auger, Kirby-Bauer is the test. The way we do this is we have filter paper discs with antibiotics infused into them, a certain amount. We put them on here, we grow it, and we measure the area where the bacteria do not grow. That's called the zone of inhibition. We can do some little maths with this. So we already had these kind of charts set up and figure out how effective that antibiotic is against that bacteria based on how big the zone of inhibition is. Now the trick is, each zone of inhibition for each antibiotic is different because some of them diffuse more quickly than others. Great example of this is penicillin. It's going to create a huge zone of inhibition because it spreads out in auger really easily. But something like gentamicin, tiny little zone of inhibition. I think if you look right here really closely, there we go, vancomycin. Very, very tiny ring, but it doesn't spread out very far. This is actually considered susceptible. It's tiny, tiny ring. So there you go. The way you do this, you're going to do a four-way streak plate because we want to prevent any kind of large gaps in this. So we're going to take swabs and we're going to streak up and down like this. We're going to turn it 90 degrees, do it again, and do it again the fourth time. And now you can see that there's no big gaps and creates even lawn of growth, which is exactly what we want. We will then take the dispenser, which we'll show you guys how to use, and clip off all the discs that we need, and we'll just let them sit on there, incubate them upside down, and we'll create the zone of inhibitions. We will also do another one called an E-test. E-test tells us the minimum inhibitory concentration, the MIC, and we basically just put these strips on here that have different amounts, gradients of antibiotics. Sorry, wrong thing. Here you go, and you guys can see it. And we basically look where we can first see that it's no longer, where it's killing bacteria and where it starts killing off the bacteria, there's no growth. We'd say, okay, that's the minimum inhibitory concentration. We don't really pay attention too much up here because it just spreads out weirdly at the top, so we just don't do anything here. We just kind of want to look in these areas right here. And so we can see, like for this one, the minimum inhibitory concentration is 0.006 for this one. So that's, I forget what it's in. It's probably in milligrams, so that's 6 micrograms of that. So there you go. And that one's really easy. And your TA will probably help you guys do this because we don't want to contaminate these strips. And you're going to have to put them down properly, but we'll do 1 strip per group of 2. So that's how this will be done. So per group of 2, you guys will get 1 type of bacteria. The other group of 2 will do another type of bacteria, and you'll just replicate this with different bacteria. Everybody has different bacteria. We'll look at them at the end, and there you go. It's actually pretty fun and easy. The next one is chemical control. So these are things like antiseptics, disinfectants, non-antibiotic ones. You should know the difference between disinfectant and antiseptic. They're actually really easy to differentiate. Disinfectants are always applied to inanimate objects, surfaces that might have bacteria on them. These great examples are bleach or Lysol. You also want to have an antiseptic, which is something applied to living tissue to prevent contamination or infection. So examples are alcohol or iodine. Most people have rubbing alcohol in their house. Same kind of thing. Now, each of these, sometimes it's concentration dependent. So for example, if you have very high concentration alcohol, you can kill off a lot more bacteria and use it as a disinfectant. But at a lower concentration, you can put it on living tissue and it's fine. Generally speaking, you don't put bleach on living tissue. However, at a slightly lower concentration, we can actually put it in living tissue. People will soak it in bandages and pack it into wounds where you have necrotizing fasciitis because it's really, really, really good at killing that. High burst oxygen kills off those bacteria really well. And so sometimes they will pack the wounds with light bleach soaked solutions and do that. They'll also use barometric pressure chambers to increase the amount of oxygen the person's breathing in, so it saturates their whole bloodstream with high oxygen, and that also kills off that bacteria. It's actually a really interesting method. Uncommon, but it does happen. So different types. There's general categories. Again, it's not a complete list of categories, but it's the major common ones. All phenolic compounds, we'll talk about a couple of these. It includes things like Lysol. Alcohols, halogens, quaternary ammonia compounds, and hydrogen peroxide, which is its own little category on its own. Phenolic compounds, same kind of thing, mode of action. Breaks down cell membranes, denatures proteins. It can be used as an antiseptic or disinfectant depending on concentration and which chemical you're using. So for example, phenol You don't want to put phenol on you because it's hepatotoxic. Back in the day, though, chemists used to wash their hands in phenol because that would get rid of the chemicals on their hands, which of course gets absorbed by your skin, and now you've got hepatic injury from rubbing phenol on your hands. And then they switched to hexane, which does the same thing. And now they don't do that at all. A commonly used medicine was hexachloroquine. We used to use this in the hospitals all the time, and we still use it to treat acne because it's actually really good at killing things, but it's neurotoxic specifically to infants. And so we actually found out for a while, we noticed in hospitals that there was an increase in infant mortality and infant brain issues. And we couldn't figure it out for the longest time. We eventually figured out that it was hexachloroquine that was being used to clean the hospitals. And so in a lot of hospitals, they don't use it anymore because of that. And that's the little basic structure. So it's got the little phenol rings on it. So a little ring structure with an OH, phenols. Okay, quaternary ammonia compounds are another one. They break down cell walls by lowering surface tension and denaturing proteins. It's basically just a soap. It's got a long nonpolar tail and a polar head. Common one, acetylpyridinium chloride. It's found in mouthwash all the time. It's typically only an antiseptic. It's not very good at killing things like spores and viruses, or organic debris can interfere with it. It's just not great at killing things, but it's pretty harmless for you to have it. So that's why it's used for mouthwash. Common. Halogens, oxidizing agents. They are really good at interacting with and reacting with things like nucleotides and lipids and proteins and amino acids, all sorts of things. Organic debris typically interferes with this, so it's not very good if there's a lot of stuff in the thing you're trying to disinfect. So like water that's got a lot of particles in it won't work very well. Small amounts may not kill something. So for example, iodine, but it will cause mutations that will kill it over time. So it may not be an immediate kill, but it may kill it over time. Still doing good on time, so I'll keep going. Common ways we treat water is with chlorine or fluorine or even iodine tablets. Really work very well for drinking water. Chlorine and bromine are used for swimming pool water. It's very, very good at killing things in water sources that are clean, and again, no organic debris. Okay, alcohols. Mode of action: denaturing proteins, dissolving lipid membranes, can create some hydrolytic reactions. You know, it's a thing in hand sanitizer. Alcohols can be used both as disinfectants and antiseptics. They have to be at a very high concentration, typically 70 to 80%. The main component in hand sanitizers is ethyl alcohols. Some places they use different ones depending on regulations, but it's pretty good at some things. It's not really good at things like spores or something that needs long times of interaction to kill, because obviously alcohols evaporate, and so they're not there anymore. Now, in this category is also what we use in the lab, which is Cavicide. Now, if you guys look at the website for Cavicide, which is from Metrics, they have all these kill claims, which is it can kill Mycobacterium, it can kill Pseudomonas aeruginosa, Salmonella enterica, Staphylococcus aureus, this fungi, which I'm not going to say, other kinds of things given a small amount of exposure time. It's also one of the few chemicals rated for SARS-CoV-2 in hospitals, which is actually very hard to do. So it's got all these things that it can kill. Now, if you guys remember, it's got an alcohol in it. It's mostly alcohol. Actually, it's mostly water. And so if you guys remember, we said, hey, it's got to be like 70 to 80% alcohol to work. But this is much lower, using isopropanol. And isopropanol is what's rubbing alcohol effectively. The reason why this works is because of the alcohol and also these other additives here. So this guy, 2-butoxyethanol, which is this guy right here. And this guy, which is diisobutophenyl ethyl oxy ethyl diamenzyl ammonium chloride, which is this guy right here. These have different properties of actually different chemicals that we're looking at. So this is similar to the benzalkonium chloride, which is another type of surfactant that we have. This has got alcohol base here, but it's very long-lived. These heavily methylated groups, thus the name diisobutanol, the methyl groups. And then it's got a chlorine molecule as well. As it degrades, it will create more reactive oxygen species with the chlorine that's present in it. And you can see it's only a small amount here, but these work very, very well. And these are actually all, these last two right here, are very toxic to humans, in high concentrations, but in low concentrations or cleaning it off and removing it, it degrades fast enough that it doesn't cause problems in hospitals. So that's the reason why it's incorporated into this disinfectant solution, because it's small concentrations which bacteria can't survive, and then we of course wipe it off, and because of the alcohol, it evaporates and it degrades super quick. It's actually a really cool setup. Okay, hydrogen peroxide. It's an oxidizing agent, just like the halogens, but it works a little better. It doesn't care about stuff in the water. It doesn't care about organic debris. It's very, very effective. The typical format is about 3 to 10%, usually about 3% in normal household concentrations. Anything above this, it's actually basically just a bomb. So that's why they don't sell it that way. If you try to buy it, they will ask you questions about why. So keep that in mind. Organic debris doesn't really interfere with this. It works really well. Now, if you guys remember, we were talking about catalase and other types of enzymes that handle hydrogen peroxide species. This does not interfere with this. Even though there's bubbles being created, the bubbles don't mean that it's working. It can work without bubbles being present. But if you see bubbles, it doesn't mean the bacteria is resisting it. It's just the enzyme working really well. It's actually killing off the bacteria in huge amounts. It's just the enzymes work really good at producing bubbles. So even if you don't see bubbles, it's fine. It's still working. Okay. Now, before I let you guys go, does anybody have any questions over anything we've covered? Make sense? All right. I will see you guys next week, and we will talk more about lab practical stuff then. Make sure you guys ask your TAs lots of questions. Super hard ones. Make them work for the jobs. And have a safe weekend, guys.